all the White Army members after a long time. Today we are going to talk about a very, very important topic. I feel a real exam topic, paraplegia for postgraduate students. As hemiplegia is important for undergraduate students, paraplegia is very, very important for postgraduate MD internal medicine students. So I already touched upon hemiplegia and stroke localization in my last class, basically meant for undergraduates. So today I'll be talking about paraplegia and localization, A to Z concepts. I assure you that if you can give me your attention for 1.5 hours, almost all the concepts of paraplegia will be covered in this lecture, which will probably last for about 1.5 hours or so. A to Z concepts. Yeah. First of all, I would like to thank the White Army. Special thanks to Dr. Kishan Rao. He's the founder and chief of the White Army and doing post-graduation super specialty in MCH cardiothoracic surgery. I thank you, sir, for giving me such a wonderful opportunity, because with this platform, I can address students across the entire country. Yeah, as the introductory comments made by my postgraduate students, I'm the medical author of the book Focused Neurology, where I put in all the important neurology concepts in a question and answer format. You can get this book online from all leading bookshops, especially Amazon. I also have a YouTube channel, Dr. Sreenivas Medical Concepts, wherein there are 5,730 subscribers. I've uploaded almost 220 neurology videos. I've discussed in length about individual topics of neurology. So if you have any doubts after listening to this lecture, you can go back to my YouTube channel, Dr. Sreenivas Medical Concepts, for a detailed understanding of individual subtopics of neurology and especially paraplegia. Dr. Sreenivas Medical Concepts, my YouTube channel. Yeah, I've got a lot of appreciation and accomplishments, including my book, Focused Neurology, being placed in one of the prestigious medical colleges of India, CMC, Vellore, Christian Medical College, Vellore Library. Yeah, over to the topic, paraplegia and localization, A to Z concepts. This is Dr. Sreenivas, consultant neurologist from Rajahmundry, Andhra Pradesh, India. I'm also the owner of the YouTube channel, Dr. Sreenivas Medical Concepts. If you have any doubts, or if you would like to communicate to me, you can communicate on my email, sreeklpm@gmail.com. As I said in the beginning of this lecture, almost all the concepts, A to Z concepts of paraplegia, I'm trying to cover in this 1.5 hours lecture. All I need is your kind attention. Right. Spinal cord disorders and paraplegia. In a small cross-sectional area, almost the entire motor output and sensory input of the trunk and limbs are present, and therefore diseases of the spinal cord can be really devastating. A small lesion of the spinal cord can really produce devastating clinical manifestations. The knowledge of the anatomy and the clinical features of spinal cord diseases is required for the successful localization of spinal cord disorders. The spinal cord is actually an extension of the CNS contained within the bony spinal canal. It originates at the level of the medulla oblongata and continues caudally to the conus medullaris at the lumbar level. The adult spinal cord is enlarged at the cervical level and the lumbar level, where neurons that innervate the upper and lower extremities respectively are located. Because there's innervation of the upper limbs and the lower limbs, so the spinal cord is enlarged at the cervical cord so as to give nerve supply to the upper limbs, and enlarged at the lumbar level so as to give the nerves to the lower limbs. So spinal cord also, we have the white matter and the gray matter, and unlike the brain, the gray matter is in the center and the white matter is in the periphery. The white matter, as you all are aware, contains the tracts. the ascending sensory tracts and the descending motor tracts. So the white matter tracts contain ascending sensory and descending motor pathways and are located peripherally. Whereas nerve cells, that is the gray matter, nerve cells are present in the inner region of gray matter that surrounds the central canal. Actually, it's an extension, anatomical extension of the fourth ventricle. The spinal cord has 31 segments, each defined by an exiting ventral motor route and an entering dorsal sensory route. So this is the transverse section of the spinal cord, and this is going to be very, very important to understand paraplegia and localization of the paraplegia. Here you can see in this diagram, you have the posterior columns. This is the ascending tracts. These are the descending motor tracts. So ascending tracts, two very important tracts are the posterior column, which are placed in the posterior most part of the spinal cord. Why is this important? The posterior column is supplied by the posterior spinal artery. And therefore, when there's an anterior spinal artery lesion, all the tracts of the spinal cord get affected except posterior column, because posterior column is placed posteriorly and is supplied by the posterior spinal artery. And when we talk about the ascending tracts, very, very important is the spinothalamic tract, the lateral spinothalamic tract. It carries pain and temperature, which is very important. We have the ventral spinothalamic tract, which carries pressure and touch. That is not very important and very significant. More important is this lateral spinothalamic tract, which carries pain and temperature sensation. Here you need to have a very, very important clinical concepts. The spinothalamic tract, unlike posterior column and pyramidal tract, it crosses immediately. It doesn't just one or two segments and crosses immediately to the opposite side and then enters the medulla oblongata and finally the cortex. So it crosses one or two segments immediately in the spinal cord. So what happens as it begins from the lower limb, thorax and the upper limb, the lower limb fibers first cross and then go to the lateral most part, and then the thorax crosses and then comes the next lateral most part, and then the upper limbs comes, which becomes more medial. This is very, very important in understanding an extramedullary compression and intramedullary lesion. So whenever an extramedullary lesion comes from outside and starts compressing the spinal cord, it is first the lower limb fibers, which are peripheral most, get affected, followed by thorax, followed by upper limb fibers. So it will be an ascending type of sensory loss. First the lower limbs, then the thorax, and then the upper limbs. So it will be like an ascending type of sensory loss. And the first fibers to get affected are the sacral fibers. So sacral sensory loss is very, very characteristic of extramedullary compression. So you can see in the diagram, the sacral fibers are the peripheral most, followed by the lumbar and then thorax and then the cervical region. Very, very important. But if you see in the posterior column, it is just the reverse of the spinothalamic tract lesions. Here you can see that the sacral lumbar fibers are medially placed and thorax cervical fibers are laterally placed. So very, very important. I repeat, very, very important to understand is that in spinothalamic tract, the lower limb fibers are placed laterally and upper limb fibers are placed medially. And therefore, if it is an intramedullary lesion coming from within the spinal cord, the lower limb fibers or the sacral fibers are spared, known as sacral sparing, very characteristic of an intramedullary lesion. Whereas if a lesion comes from outside and starts compressing the spinal cord, the sacral fibers are the first to get affected. So sacral sensory loss is very characteristic of extramedullary lesion. So then you can see the spinocerebellar tracts, dorsal and ventral. They are important for proprioception, for the understanding of the joint position sense, which is conveyed to the cerebellum. In fact, at an unconscious level, at a subconscious and unconscious state, it keeps giving information. So even when we are talking to others or moving about, we are aware of the position of the body at a subconscious level. We are not actually, even though we don't use our consciousness, automatically we are aware it is because of these spinocerebellar tracts. So this is all about the ascending tracts. Very, very important. Two tracts. One is the posterior column. Second is the spinothalamic tract. Posterior column carries touch, position, joint, vibration, sense, and the fibers ascend in the spinal cord but cross at the level of the medulla oblongata. Second is the spinothalamic tract, which is very, very important, which carries pain and temperature sensation. A very important concept is that it doesn't just one or two segments in the spinal cord and immediately crosses over to the opposite side and then ascends. The sacral fibers are the peripheral most, and therefore when an extraneous compression comes, the sacral fibers are the first to get affected. Whereas if it's an intramedullary lesion, sacral fibers are the last to get affected because they are placed laterally. Another important point about the spinothalamic tract is that, as I said, it ascends one or two segments and immediately crosses over to the opposite side and then ascends. So any lesion in the center part of the spinal cord will affect the crossing spinothalamic tract, but the posterior column fibers are spared. So if the lesion arises in the center part of the spinal cord, it affects the crossing spinothalamic tract because spinothalamic tract traverses the spinal cord and then ascends, whereas posterior column ascends peripherally and then cross at the level of the medulla oblongata. So if there's a central cord lesion, it affects the crossing spinothalamic tract fibers, but spares the posterior column sensations. So the spinothalamic tract sensations are affected and posterior column sensations are spared. So there is a dissociation of sensory loss. It is known as dissociated sensory loss, very, very characteristic of syringomyelia. So if there's a syringomyelia, a developmental abnormality in the center of the cord, it goes and affects the crossing spinothalamic tracts, and therefore the sensations carried by spinothalamic tract, namely pain and temperature, are affected, but sensations carried by posterior column, namely touch, position, joint, vibration, sense, are spared. So dissociation means going away, association means coming together. So dissociated sensory loss, very, very characteristic of syringomyelia. I think you can understand the excitement of this dissociated sensory loss. Generally, what happens in a normal person, when a person touches me, I may not be aware of it, but when a person pinches me, the pain, I'm immediately aware and take away my hand away. So pain is very, very sensitive. But here are the patients with syringomyelia where pain is absent and touch is present. So someone touches them, they appreciate, but they keep their hand in the fire, they're not able to appreciate. In fact, they can have burns, especially if persons unknowingly, if they keep the hand in the fire, they'll not be able to appreciate the painful sensations because the spinothalamic tract gets affected. It may result in burns. So any persons who's got absence of pain but presence of touch, very, very important, very, very interesting. It is syringomyelia. These are all about the ascending tracts. And then coming to the descending tracts, the most important is the corticospinal tract, the lateral corticospinal tract, which is the primary tract, which is supplying all the muscles and is responsible for the movements. Then we have the other tracts like vestibulospinal tract, which becomes very important in understanding paraplegia and extension and paraplegia and flexion. You can see the vestibulospinal tract, it is placed here. It is responsible for extension. So if there is a partial or incomplete spinal cord lesion, the vestibulospinal tract may be spared and resulting in paraplegia in extension, because vestibulospinal tract causes extension. But if a lesion is complete, affecting even the vestibulospinal tract, so the extension cannot take place because vestibulospinal tract is affected. So it will result in paraplegia and flexion and flexor spasms. Very, very important in understanding the concept of paraplegia and extension and paraplegia and flexion. Paraplegia and extension indicates an incomplete transverse cord lesion because the vestibulospinal tracts are spared, which are responsible for extension. But when there's a complete transaction, including vestibulospinal tract, the extension which is done by vestibulospinal tract is affected, resulting in paraplegia and flexion and flexor spasms. So you can see here the corticospinal tract, which is responsible for the movements, is placed in the lateral part of the corticospinal tract. Another very important point in the corticospinal tract, when I'm talking about the medulla oblongata lesion, I would be telling, when it descends, it maintains the anatomy. The lower limb fibers are medially placed and the upper limb fibers are laterally placed. But when the lower limb fibers and the upper limb fibers cross at the level of the medulla oblongata, now what happens? The lower limb fibers are placed laterally and upper limb fibers are placed medially once it has crossed over. So after the corticospinal tract crosses over, if there's a lesion, for example, in the cervical cord, so what happens? There is involvement of the lower limb, then upper limb, and then upper limb. This is known as U-shape, known as an Ellsberg's phenomenon. So here you can see here how the fibers are placed. Right. Another important point is that corticospinal tract crosses at the level of the medulla oblongata. Upper limb fibers cross above and the lower limb fibers cross below. So various permutations and combinations can occur at the level of the medulla oblongata. If only the lesion is at the upper level, only the upper limb fibers get affected. So patient will have only upper limb weakness. I'm talking about the medulla oblongata where the fibers are crossing. If there's a lesion only at the level cyclic caudally, only the lower limb fibers get affected. So they can have only paraparesis. But if there's a lesion here and here where the upper limb fibers, crossed upper limb fibers and uncrossed lower limb fibers get affected, it may result in cruciate hemiplegia. Weakness on one upper limb on one side and lower limb weakness on the other side. Very, very interesting. If we see cruciate hemiplegia, weakness of upper limb on one side and weakness of lower limb on other side, it is cruciate hemiplegia. So paraplegia, yeah, true. By and large, it is a spinal cord lesion, but a cerebral cause also can give rise to paraplegia at two levels. One at the cerebral cortex, medial part of the frontal lobe, where the anterior cerebral artery supplies the leg area. So if both the anterior cerebral arteries get affected, the leg areas get affected, it can result in paraplegia. So one important cerebral cause of paraplegia is involvement of both anterior cerebral arteries affecting the leg area. The second place where a brain lesion can cause paraplegia is in the medulla oblongata, where the lower limb fibers slightly cross below. So if there's a lesion there, only the lower limbs selectively get affected. So when they ask you in the exams, what are the cerebral cause of paraplegia? It can occur in two places. One, both the anterior cerebral arteries getting involved. Second, in the medulla oblongata, where the lower limb fibers slightly cross caudal to the upper limb fibers. So if there's a lesion there, only the lower limb gets affected. So these are all the very, very important concepts one need to understand before we approach a case of paraplegia. Right. There's a discrepancy between roots and vertebral bodies. During embryologic development, growth of the cord lags behind that of the vertebral column, and the mature spinal cord ends at L1 vertebral body. Again, an important concept, when we do lumbar puncture, we go below L1, say L3, L4. Why do we go below L1? Because the spinal cord ends at the L1, so we are safe to perform a lumbar puncture. If we go above L1, we are likely to injure spinal cord. And therefore, when we perform lumbar puncture or cerebrospinal fluid analysis, especially for paraplegia, to elucidate the cause of paraplegia, like infectious causes or demyelinative causes, inflammatory cause, when we do LP-CSF analysis, we have to choose a space well below L1 so as to not to injure the spinal cord. So generally we go at the L3, L4 level. Second, since the spinal cord ends at the L1 vertebral level, the lower spinal nerves take an increasingly downward course to exit via the intervertebral foramina. The relationship between the spinal cord segments and the corresponding vertebral bodies are as follows. Since the spinal cord ends at the level of the L1, there's a discrepancy between the spinal cord segments and the vertebral segments. So it ends at the level of the L1. So spinal cord level ends at the level of the L1. So all the sacral and coccygeal segments are at the level of the L1. T10 corresponds to L1, L2. T11 corresponds to L3. T12 to L5, S1. And the L1 corresponds to all sacral and coccygeal segments. So spinal cord level corresponding vertebral level. Upper cervical, they are the same as cord level. But when you come to the lower cervical, one level higher, upper thoracic 2 levels higher, lower thoracic 2 to 3 levels higher, lumbar corresponds to T10 to T12, and sacral corresponds to T12 to L1. Very, very important. For example, we say umbilicus is T10, that is the spinal level, but if you take the vertebral level, it will be around T10, T11. One more important point is that there are 7 pairs of spinal nerves, but there are 8 cervical cord segments. Very, very important. Again, there's another discrepancy between roots and vertebral bodies. The first 7 pairs of spinal nerves exit above the same number of vertebral bodies, whereas all the subsequent nerves exit below the same numbered vertebral bodies because of the presence of 8 cervical cord segments, but only 7 cervical vertebrae. This becomes very important when we talk about lumbar disc prolapse. So in the cervical region, the nerve root exits above the respective cervical vertebra. For example, C5 is above C5, C6 above C6. But when it comes below C7, because there are 8 cervical roots and only 7 cervical roots and 8 cervical cord segments, when it comes to lower level, it starts exiting below. So the T1 nerve comes below T1 vertebral level, L5 nerve comes below the L5 vertebral level. So above the C7, the nerves exit above the respective vertebral segments, but below the C7, C8, it starts exiting one segment below the corresponding vertebral body. The first 7 pairs of spinal nerves exit above the same numbered vertebral bodies, whereas all the subsequent nerves exit below the same numbered vertebral bodies because the presence of 8 cervical cord segments, but only 7 cervical vertebrae. The presence of a horizontally defined level below which sensory, motor, and autonomic function is impaired is a hallmark of a lesion of the spinal cord. So if there's a definite level below which motor, sensory, and autonomic disturbances are present, it is a hallmark of a lesion of spinal cord. Sensory level below this level is the result of damage to the spinothalamic tract on the opposite side, 1 to 2 segments higher in the case of unilateral spinal cord lesion and at the level of the bilateral lesion. So if there's a hemicord, the spinothalamic tract gets affected. You remember I told in the beginning of the class that the spinal cord 1 to 2 segments it ascends and immediately crosses over to the opposite side. So if there's a hemisection of the cord, the spinothalamic tract gets affected. So the manifestations will be 1 to 2 segments below on the opposite side if it's a unilateral lesion. If there's a bilateral lesions, even the cervical, even the roots get affected, the dorsal roots get affected. So the level of the lesion corresponds to the transaction. But if it is a unilateral, the manifestations will be 1 to 2 segments below on the opposite side. So sensory level below this level is the result of a damage to the spinothalamic tract on the opposite side, 1 to 2 segments higher in the case of a unilateral spinal cord lesion and at the level of a bilateral lesion. The discrepancy in the level of a unilateral lesion is the result of the course of the secondary order sensory fibers which originate in the dorsal horn and ascend 1 or 2 levels as they cross anterior to the central canal to join the opposite spinothalamic tract. Lesions that transect corticospinal and other motor tracts cause paraplegia or quadriplegia with heightened deep tendon reflexes, Babinski signs, and eventual spasticity, upper motor neuron syndrome. So when it transects, the corticospinal tract gets affected. We get upper motor neuron features like increased deep tendon reflexes. There's an extensor plantar response and eventual spasticity. That is the class nice spasticity. Transverse damage to the cord also produces autonomic disturbances consisting of absent sweating below the cord level and bowel, bladder, and sexual functions. So if there's a lesion in the spinal cord, bowel, bladder, and sexual functions also get affected, again in favor of a spinal cord lesion. The uppermost level of a spinal cord lesion can be localized by the segmental signs like dorsal root, ventral root gets affected. So by the segmental signs corresponding to the distant motor or sensory innervations by an individual cord segments. A band of altered sensation, hyperalgesia or hyperpathia at the upper end of the sensory disturbance, fasciculations or atrophy in the muscles because of the anterior cell involvement, innervated by 1 or several segments, or decrease or absent reflex may be noted at this level. So when the anterior horn cell gets affected, you can have fasciculations and atrophy. It corresponds to that particular level. One important point we need to know here is, especially for postgraduates, why we try to elicit reflexes is to localize the lesion. At the level, there will be LMN signs because the anterior horn cells of the spinal cord are cut off. Below the level, there will be UM signs, and above the level, it is normal. At the level, there will be LM ensigns because the anterior horn cells are affected. Below the level, there will be UM ensigns because the corticospinal tract is affected, and above the level, it is normal. I can give you an example. For example, we'll take the lesion at L3, L4. So when there's a lesion at L3, L4, what happens? The biceps, supinator, triceps are normal because the lesion is at L3, L4. But when the L3, L4 is cut off, the anterior horn cells of L3 and L4 are affected. So knee reflex will be absent. So when the lesion is at the L3, L4, the corticospinal tract, which is coming down, is also cut off at L3, L4. So for S1, it becomes a UMN type because S1, the anterior horn cells are intact, but the corticospinal tract supplying the S1 is cut off at the level of L3, L4. So for S1, it becomes UMN. So ankle will be brisk or exaggerated. So when you are placing the lesion, at the level of the lesion, there will be LM ensigns. Below the level of the lesion, there are UM ensigns, and above the level of the lesions, it will be normal. Very, very important concept. Spinal shock. With severe and acute transverse lesions, the limbs initially may be flaccid rather than spastic, known as spinal shock, which may last for several days. So initially, it may be flaccid, which is known as spinal shock. Right. Circle of Willis is very, very important to understanding stroke and stroke localization. Likewise, we need to understand the blood supply of this spinal cord. The spinal cord is supplied by two arteries. One is the anterior spinal arteries, which is a single artery, and two, the posterior spinal arteries, which are paired arteries. So anterior spinal artery, a single anterior spinal artery, is formed by the union of arterial branches that pass caudally from each vertebral artery and unite in the midline near the foramen magnum. It supplies the entire spinal cord except the posterior part where the posterior columns lie. That's what I was telling in the beginning of my lecture. If the anterior spinal artery gets affected, there'll be all the tracts get affected except posterior column, which is placed posteriorly and supplied by the posterior spinal artery. The paired posterior spinal arteries, they also arise from the vertebral arteries, and posterior medullary arteries join them at irregular intervals. They supply the posterior part of the spinal cord where the posterior column lies. So if only the posterior column gets affected, we need to think that the posterior spinal artery is involved. Yeah, we have the reinforcement by medullary arteries. So these are the main arteries, a single anterior spinal arteries and a paired spinal arteries. But there is reinforcement occurring at each level. For example, in the cervical level, there's a reinforcement by an ascending cervical artery. At the thoracic level, there's a reinforcement by intercostal arteries. And at the abdomen, there's a reinforcement by lumbar, iliolumbar, and lateral sacral arteries. But the largest medullary artery, the main reinforcement, the largest medullary artery known as Adam-Key-Wicks, the largest medullary artery, the great anterior radicular artery of Adam-Key-Wicks, arises at the level of T9 and L2. So it gets a good blood supply. So the watershed area is about T9. So usually it is around T4. So the upper thoracic segments near T4 have been traditionally thought particularly vulnerable to ischemia. It's a watershed. Here you have the main arteries and there's a reinforcement. But as you come down, the blood supply slightly decreased and there's a reinforcement only at the lower level, T9 to T12. So the T4 area is particularly vulnerable to ischemic changes. So here you can see the blood supply again. You can see the posterior spinal artery here. And here you can see the anterior spinal artery. Here you can see the anterior spinal artery here, it supplies the area, and here you can get from, see, you can see the lateral spinal artery, intercostal arteries. This is what I've been saying. So it gets reinforced, the medullary arteries, it gets reinforced by intercostal arteries. So you have the main anterior supply artery, a single anterior supply artery, and you have two paired spinal arteries, and it gets reinforced by all these medullary arteries which come and reinforced at every level. In the thorax, it is by intercostal arteries. So the posterior column is supplied by the posterior spinal artery. Other than the posterior column, the entire spinal cord is supplied by the anterior spinal artery. Yeah, now we shall come to the localization. How do we localize, whether it is the cervical cord level, thoracic level, or lumbar level? If it is the cervical cord level, upper cervical cord lesions produces quadriplegia and weakness of the diaphragm. The diaphragm also gets affected and it produces quadriplegia because the lesion is C4 and below. So C4, C5 starts affecting, you have C5, C6 biceps, you have upper limbs and the lower limb getting affected. The diaphragm gets affected, C3, C4, C5. So upper cervical cord lesions produce quadriplegia and weakness of the diaphragm. The uppermost level of weakness and reflex losses with lesions at C5, C6 is if C5 is involved. Easy way to remember is C5 innervated muscles are, remember the acronym BIRDS, B-I-R-D-S. C5 innervated muscles are BIRDS, B-I-R-D-S. Biceps, infraspinatus, rhomboid, deltoid, and supraspinatus. So if C5 and 6 is involved, biceps jerk is lost because biceps, the root value is C5, C6. If C7 gets affected, triceps, finger and wrist extension is affected. And if C8 gets affected, finger and wrist flexion gets affected. And lesion at any level of the cervical cord, because the sympathetic tract comes till the level of T1. So lesion at any level of the cervical cord causes Horner syndrome. That is the sympathetic tract being affected. It produces miosis, ptosis, and facial hypohidrosis. Sympathetic tract causes dilatation of the pupil. So when the sympathetic tract gets affected, there's miosis. The tarsal muscle, which is responsible for an extension of the eyelid, that gets affected. So there's ptosis, and sweating gets affected, facial hypohidrosis. So if you have features of Horner syndrome, the lesion should be above T1, that is at any level of the cervical cord. Yeah. Next, we come to the thoracic cord. Lesions here are localized by the sensory level on the trunk and if present by the site of midline back pain. We don't have much muscles of significance to localize it by motor level. So we go by more of sensory level at the thoracic cord. So lesions here are localized by the sensory level on the trunk and if present by the site of midline back pain. However, there are useful markers of sensory level on the trunk. The nipples corresponds to T4 and umbilicus corresponds to T10. So we don't have much of motor, but sensory level, yeah, by sensory level, we can localize in the thoracic cord. And useful markers is nipples, the level is T4, umbilicus, the level is T10. And one important sign they'll always ask in exam when you get a case of paraplegia is, what is Beaver's sign? Very, very important. I repeat, Beaver's sign is very, very important, especially for postgraduate examinations. If there's a lesion at T10, it paralyzes the lower, but not the upper abdominal muscles. So resulting in upward movement of the umbilicus when the abdominal wall contracts. When you ask the person who is supine to come to sit, what happens? He contracts the abdominal muscles. But then if there's a lesion at T10, what happens? The lower abdominal muscles cannot contract. The upper abdominal muscles, as usual, will contract and will pull the umbilicus upwards because umbilicus is T10. So the movement of umbilicus is upwards. So if we see the movement of the umbilicus upwards, we know the lesion is at T10, and this is known as Beaver's sign. Now we go to the lumbar level. So lumbar level L2, L3, L4, it paralyzes flexion and adduction of the thigh, iliopsoas and adductors, and weakens knee extension, that is quadriceps at the knee, because quadriceps is L2, L3, L4. It abolishes the patellar reflex, that is L3 and L4. If the lesion is at the level of the L5, S1, it paralyzes the movements of the foot and ankle and flexion of the knee, that is hamstrings, and extension of the thigh, that is gluteus medius. They're all supplied by L5, S1, and this abolishes the ankle jerk. So L5, S1 abolishes the ankle jerk, L2, L3, L4 abolishes the patellar reflex. Another important way is to find out clinically about L5, S1 is that L5 is mainly for dorsiflexors. So patient is able to walk on heels if L5 is intact. S1 is for plantar flexion. So if the person S1 is intact, is able to walk on toes. So if a person is not able to walk on toes, that means the plantar flexion is affected. That means S1 is affected. If a person is not able to walk on heels, that means dorsiflexion is affected. That means L5 is affected. So this is the diagram depicting the various cord segments. Right. Now conus medullaris. Again, very, very important. Two important questions an MD student can expect in a case of paraplegia is one, what are all the differences between conus medullaris and chordoichmenial lesion? And what are all the differences between an extramedullary and intramedullary lesion? These are the most important questions one will be asked in the MD general medicine examination. So conus medullaris. So what is conus medullaris? The conus medullaris is the tapered caudal termination of the spinal cord comprising the sacral and single coccygeal segments. The conus syndrome consists of, so it is basically the distalmost point of the spinal cord. So basically sacral segments, distalmost point, that is L1. Spinal cord ends at the level of the L1. It contains sacral and coccygeal segments. So the distalmost point, it contains the sacral segments. So what are the sacral segments? So what is the manifestation? So sacral segments are primarily lost. The bilateral saddle anesthesia, S3, S4, S5. S3, S4, S5 gets affected. So they'll have saddle anesthesia, the prominent bladder and bowel dysfunction, urinary retention and continence with lax anal tone and impotence. Bulbocavernous is S2, S3, S4. Anal is S4, S5. Reflexes are lost. Muscle strength is largely preserved. So it is usually below S2. So most of the muscles are preserved because the lesion is below S1. So we have to go for all these other signs. So bilateral saddle anesthesia, bowel bladder involvement, sexual dysfunction, bulbocavernous and anal reflexes are lost, and muscle strength is largely preserved in a conus medullaris lesion because only the sacral segments get affected, especially S2 and below. But what is cauda equina? Cauda equina, it is from the Latin word horse's tail. It's a bundle of spinal nerves and nerve roots consisting of 2nd through 5th lumbar nerve pairs. So L2 and below, easy to remember, L2 and below is cauda equina, S2 and below is the conus medullaris. So of the 2nd to the 5th lumbar pairs, the 1st through 5th sacral nerve pains and the coccygeal nerve, all of which arise from the lumbar enlargement and the conus medullaris of the spinal cord. So they are just the nerve roots, horse tail, below T10, that is L2 level. So how are the cauda equina lesions? How do they manifest? They are characterized by low back and radicular pain. Always remember, an important cause for cauda equina is disc prolapse. A disc below L1. So the spinal cord ends. So it affects only the roots. So one of the important causes of cauda equina lesions is disc prolapse. They are characterized by low back and radicular pain. Asymmetric because it can go only on one side. Remember again, disc prolapse. When you're talking about cauda equina, always try to remember disc prolapse and it becomes easy. Lumbar disc prolapse. So asymmetric, generally it is a posterolateral disc. So there's only one side. Asymmetrical leg weakness and sensory loss. Variable areflexia in the lower extremities. So the reflex level depends upon the root which is involved. If it is L3, L4, knee jerk gets affected. If it is S1, ankle jerk gets affected. And relative sparing of bowel and bladder function because they are at the level of the sacral level. So usually they are characterized by low back and radicular pain. Asymmetric, that is the catchword. Asymmetric leg weakness and sensory loss because conus medullaris is the tip of the lesion. So it is usually symmetrical. Whereas cauda equina is root. So it is usually asymmetrical. Remember, disc prolapse. Varial areflexia in the lower extremities and relative sparing of bowel and bladder function. Note, mass lesions in the lower spinal cord often produce a mixed clinical picture with the elements of cauda equina and conus medullaris lesions. So summarizing all the important points between conus medullaris and cauda equina, this is the question which will be expected of you when you present a case of paraplegia. What are all the differences between conus medullaris and cauda equina? The spontaneous pain. Conus medullaris is the spinal cord and the cauda equina is the root. So when the spinal cord is affected, the pain, it is not common or severe, bilateral and symmetrical in the perineum of the thighs. S2, S3, S4, S3, S4, S5 gets affected. It's the tip of the spinal cord. Whereas when the roots get affected, the pain will be maximum, maybe most prominent symptom. Severe radicular in type, unilateral or asymmetric in type. Saddle distribution in conus medullaris, S3, S4, S5. Bilateral, usually symmetric. Dissociation of sensation may be present. Since the spinal cord gets affected, the center, the crossing spinothalamic tract can get affected, sparing the posterior column. So dissociated sensory loss can be present in any case of a spinal cord lesion where the spinothalamic tract gets affected. So pain and temperature gets affected and posterior columns are lost. Because pain is affected, there can be decubitus, there can be ulcers. Whereas if it's a cauda equina lesion, it's a saddle distribution, but maybe unilateral and asymmetrical because it's a root, All forms affected, no dissociation of sensations because it is root gets affected. So all sensations are equally getting affected. If it is spinal cord lesion, if it is a central cord, only the spinothalamic tract gets affected. So there's a dissociation of sensation. Whereas when it comes to roots, all sensations get affected, and the ulcers are less common as compared to the conus medullaris lesion. Motor loss, again symmetric, not marked because it is usually at the level of S2, S3, S4, so not marked. Fasciculations may be present because it's a spinal cord lesion, anterior horn cell may get affected, so fasciculations may be present. Whereas if it is chorda equina, it is asymmetric, more marked, atrophy may occur, usually no fasciculations. Reflex loss, since the lesion is S2 and below, sometimes S1 also, what we call as epiconus, ankle reflex may be absent. But in chorda equina lesions, the lesion is below L2, so both patellar and ankle reflex may be absent. Bladder, erectile, sexual symptoms are early and marked in conus medullaris lesion because it is a spinal cord lesion. Whereas since it's a chorda equina is a root lesion, they are late and less marked. The bladder, bowel, and sexual symptoms are late and less marked. It's a conus medullaris lesion, so it will be sudden and bilateral. Whereas chorda equina, they are gradual and unilateral. So these are all the important differences between conus medullaris and chorda equina lesion, and you can take it almost for granted that this question will be definitely asked when you present a case of paraplegia. Yeah, what are all the other presentations? You can have a presentation of Brown-Séquard hemichord syndrome. You can have central cord syndrome, anterior spinal artery syndrome, foramen magnum syndrome, intramedullary and extramedullary syndromes. Brown-Séquard syndrome. What is Brown-Séquard syndrome? Now, having understood all the pathophysiologic mechanisms and understanding of the anatomy of the spinal cord, now it becomes easy to approach all these syndromes. Brown-Séquard syndrome is a hemisection of the spinal cord. Only one section of the spinal cord is cut off. So what happens? The posterior column and pyramidal tract are affected on the same side because they have already crossed at the level of the medulla oblongata and descending. But the spinothalamic tract, it ascends and crosses over to the opposite side, 1 or 2 segments higher. So when there's a hemisection of the spinal cord, posterior column and pyramidal tract are affected on the same side. Spinothalamic tract is affected, but the manifestations will be on the opposite side because spinothalamic tract crosses and comes over to the opposite side. So when there's a hemisection of the spinal cord, usually because of trauma, it consists of ipsilateral weakness, corticospinal tract, loss of joint position vibrations, and because of posterior column, but with contralateral loss of pain and temperature sensations, 1 or 2 levels below the lesion. Segmental signs such as radicular pain, muscle atrophy, or loss of deep tendon reflexes are unilateral. So this is the Brown-Séquard syndrome. You can see in the diagram, the posterior column and pyramidal tract, the manifestations are on the same side, but the manifestations of the spinothalamic tract given in a blue color is on the opposite side. The paralysis, red color, corticospinal tract, and the posterior column, the manifestations are on the same side. Central cord syndrome. Central cord syndrome is the central part of the spinal cord getting affected. So what happens? It spares the posterior column and pyramidal tract because they cross at the level of the medulla oblongata. The only tract which crosses in the spinal cord is spinothalamic tract. So when there's a central cord lesion, it affects the crossing spinothalamic tract and spares the posterior column. So what happens? The pain and temperature are lost, but position joint vibration sense are spared. So central cord syndrome, this syndrome results from the selective damage to the gray matter nerve cells and crossing spinothalamic tract surrounding the central canal. In the cervical cord, central cord syndrome produces arm weakness out of proportion to leg weakness because it usually affects the neck region, and there's a dissociated sensory loss, meaning loss of pain and temperature and sensations over the shoulder, lower neck, and upper trunk cave distribution because it usually affects the cervical region, in contrast to the preservation of light touch joint position and in these regions. Spinal trauma, syringomyelia, and intrinsic cord tumors are the main causes. So this is a central cord syndrome wherein the crossing spinothalamic tract fibers get affected. So pain and temperature are lost, but posterior column is spared, so position joint vibration sense and touch are spared. Anterior spinal artery syndrome, as I said in the beginning of my lecture, it supplies almost all the parts of the spinal cord except the posterior column, and therefore you have manifestations of all the tracts except posterior column because it is supplied by the posterior spinal artery. So the anterior spinal artery syndrome, infarction of the cord, is generally the result of occlusion or diminished flow in this artery. The result is bilateral tissue destruction at several contiguous levels that spares the posterior columns. All spinal cord functions, motor, sensory, and autonomic, are lost below the level of the lesion, with a striking exception of the retained vibration and position sense, because it is supplied by the posterior spinal artery. So this is the supply. You can see the posterior spinal artery supplies the posterior column, anterior spinal artery supplies the all areas except the posterior column, and therefore if the posterior column has to get affected, it can get affected if it is a posterior spinal artery lesion. Foramen magnum syndrome. This is what I've been saying. The upper limb fibers cross at rostally, and the lower limb fibers crossed distally, caudally in the medulla oblongata at the level of the foramen. So what are all the various manifestations? Crural paresis, lesion in this area, descending peroneal tract fibers destined for the legs, which cross caudal to those of the arms, resulting in the weakness of the legs. Crural paresis, one of the important cerebral causes of paraplegia, is foramen magnum syndrome. Around the clock pattern. So compressive lesions near the foramen magnum may produce weakness of the ipsilateral shoulder and arm, followed by the weakness of the ipsilateral leg, then the contralateral leg, and finally the contralateral arm, and around the clock pattern that begins in any of the four limbs, which is known as the Ellsberg's phenomenon. There is typically suboccipital pain spreading to the neck and shoulders. Yeah, another important question they'll ask you is, what are the differences between intramedullary lesion and extramedullary lesion? It is useful to differentiate intramedullary process arising within the substance of the cord from extramedullary ones that lie outside the cord and compress the spinal cord or its vascular supply. So extramedullary lesion, it is coming from the outside the spinal cord and compressing. Intramedullary lesion is arising within the spinal cord and expanding. So in extramedullary lesion, radicular pain is often prominent because the dorsal root gets affected. And there is early sacral sensory loss because the spinal thalamic tract fibers cross over. So peripherally, there are sacral fibers. So they are the first to get affected in an extramedullary lesion. So sacral sensory loss and spastic weakness in the legs because the corticospinal tracts, which are placed peripherally, get affected. Anterior horizons are present in the gray matter, but corticospinal tracts are present in the white matter, that is periphery, so they get affected in an extramedullary lesion. So there's spastic weakness in the legs with incontinence due to superficial location of the corresponding sensory and motor fibers in the spinal thalamic tract and corticospinal tracts. A further distinction is made between the extradural and intradural masses, as the former are generally malignant and the later benign, neurofibroma being a common cause. Consequently, a long duration of symptoms favor an intradural lesion. Amongst the extramedullary lesions, they say extradural and intradural. Intradural is basically benign lesions like neurofibroma, so it takes a longer time to present. Whereas intramedullary lesions, they tend to produce poor localizing burning pain rather than radicular pain because it is in the spinal cord, and they tend to spare sensation in the perineal and sacral areas, because the sacral fibers are placed laterally, so they do not affect the sacral fibers, and even if they affect, they are the last to get affected. So the sacral spanning takes place. So what happens, the perineal and sacral areas are spared, reflecting the laminated configuration of the spinal thalamic tract, with the sacral fibers placed outermost and corticospinal tract signs placed appear later. Yeah. Again, a very, very important question. One is conus medullaris chorda equina differentiation. Second is a differentiation between extramedullary and intramedullary lesion. So what are the differences? Extramedullary coming from outside and compressing the spinal cord. Intramedullary is the lesion within the spinal cord. So the radicular pain is very common in extramedullary lesion because the root gets affected, whereas an intramedullary tumor, since it is only spinal cord, the radicular pain is not that common. Vertebral pain is unusual, whereas if an extramedullary lesion, usually an outside compression, like a vertebral bone coming and compressing the spinal cord. So vertebral pain is more common in extramedullary lesion. Funicular pain is more common in intramedullary lesion, less common in extramedullary lesion. Upper motor neuron signs, they appear, yes, they are present, but late, whereas in extramedullary lesion, they are present, they occur early. Because the corticospinal tract fibers are peripherally spaced, extramedullary lesions immediately come and compress the peripherally placed corticospinal tract. So the manifestations appear early, whereas in intramedullary lesion, where it comes from the center of the cord, since the corticospinal tract fibers are placed in the peripheral region, they appear late. The lower motor neuron signs, prominent and diffuse. The anterior horn cells are very much within the spinal cord in the gray matter, so they are prominent and diffuse. Whereas if it's an extramedullary lesion, they are unusual, and even if present, they are segmental in distribution. The paresthesia is progressing, that is progressive paresthesia. In intramedullary lesion, it is a descending progression. The sacral fibers are laterally placed, the thoracic fibers and the cervical fibers. So if an intramedullary lesion comes from within and starts compressing the spinal cord, cervical first gets affected, then thoracic, then sacral. So it's a descending type of paresthesia. Whereas if an extramedullary lesion affects the sacral fibers first, then the thoracic, then the cervical. So it is an ascending type of paresthesia. Sphincter abnormalities are common in intramedullary lesion, early with caudal lesions, conus medullaris and cauda equina. It is late in extramedullary lesion. Trophic changes are common in intramedullary lesions, unusual in extramedullary lesions. That dissociated sensory loss is very, very characteristic of intramedullary lesion. So it's a spinal cord lesion. So it affects the crossing spinothalamic tract, but spares the posterior column. So sensations carried by spinothalamic tract, meaning pain and temperature are affected, but sensations carried by posterior column, position joint vibration sense are spared. So dissociated sensory loss is very characteristic of intramedullary lesion, but unusual in extramedullary lesion. Sacral sparing of sensations very characteristic in intramedullary lesions because sacral fibers are peripherally placed, whereas it is unusual in extramedullary lesion. Greater impairment of position and vibration position sense is characteristic of an intramedullary lesion. The posterior column is placed within the spinal cord, the posterior cord, especially cervical spondylosis, where you have the gait ataxia, where they have imbalance in walking. The position vibration joint sense gets affected first. Very characteristic of intramedullary lesion, and it is unusual in extramedullary lesion. Very important question: intramedullary and extramedullary difference between conus medullaris and cauda equina. So diagnostic approach. Now that we know different clinical symptoms, how do we approach? Spinal cord disorders could be acute or chronic. So first you should know whether it is acute or chronic. Acute spinal cord disorders may be further classified as compressive, that is a lesion going and compressing like a metastasis, abscess which goes and compresses, or non-compressive like a demyelinative lesion or a vascular lesion which does not compress the spinal cord. So spinal cord disorders can be divided into acute and chronic. Acute spinal cord can be further divided as a compressive lesion, some mass coming and compressing the spinal cord, or non-compressive like myelitis or vascular disorders. So the first priority is to exclude treatable compression of the cord by a mass lesion. So epidural compression due to malignancy or abscess often causes warning signs of neck pain or back pain, bladder disturbances, and sensory symptoms that precede the development of paralysis. They are usually picked up by MRI. So when it's an extraneous compression like a mass, it takes a lot of time. So they'll generally have pain, back pain, if it is abscess, fever. So there'll be antecedent symptoms. It does not come suddenly. It takes some time to develop. So antecedent symptoms are present in a compressive lesion, and they are usually picked up by MRI. For example, if there's a mass, abscess, neoplasm, it is picked up by MRI. Non-compressive lesions usually produce myelopathy without antecedent symptoms. They occur suddenly. Remember transverse myelitis, and usually it is not picked up by MRI. Symptoms of the cord disease that evolve over days or weeks are focal neck pain or back pain, followed by various combinations of paresthesia, sensory loss, motor weakness, and sensory sphincter disturbances. When paresthesias begin in the feet and then ascend, a polyneuropathy is often considered, and in such cases, the presence of bladder disturbances and a sharply demarcated spinal cord level provide important clues to the spinal cord origin of the diseases. So we have compressive acute lesions, we have compressive and non-compressive. Compressive are neoplastic spinal cord compression, spinal epidural abscess, spinal epidural hematoma, acute disc herniation. Non-compressive myelopathies, we have spinal cord infarction, immune-mediated myelopathies, and infectious myelopathies. So neoplastic spinal cord compression, most often they are epidural in origin, resulting from metastasis to the adjacent spinal bones. Breast, lung, prostate are the most frequent. Thoracic cord is most commonly involved. So neoplasm or tuberculosis, it is the thoracic cord which gets affected more. Whereas if it is disc prolapse, it is cervical and lumbar region. Because we keep moving our neck here because of excessive mobility and back. Because of this excessive mobility, there's a degenerative changes. So the disc prolapse is more common where there's excessive mobility like neck causing cervical disc prolapse, or excessive mobility in the back causing lumbar disc prolapse. And second, there's not much disc prolapse in the thoracic region because it is protected by the rib cage. One, there is not much movement at the thoracic level. Second, it is protected by thoracic rib cage, and therefore disc prolapse is very unusual at thoracic level. So thoracic cord is most commonly involved in neoplastic spinal cord compression. Initial symptom is usually back pain, worst when recumbent, with local tenderness preceding other symptoms by many weeks. Spinal cord compression due to metastasis is a medical emergency in general. Therapy will not reverse paralysis more than 48 hours of duration. So we should be very, very vigilant. Spinal epidural abscess, tired of fever, localized midline dorsal pain or neck pain, and progressive limb weakness, Once neurological signs appear, cord compression rapidly progresses. Spinal epidural hematoma presents as acute focal or radicular pain, followed by variable signs of spinal cord or conus medullaris disorders. Acute disc herniation, cervical and lumbar disc herniations are more common than thoracic disc herniations because there is excessive mobility at the neck causing cervical disc prolapse and back causing lumbar disc prolapse than thoracic region. And second point, thorax is well protected by rib cage. Spinal cord infarction. So now we are coming to the non-compressive myelopathy. Anterior spinal artery infarction produces paraplegia or quadriplegia, sensory loss affecting pain and temperature sense, but sparing vibration position sense because they are supplied by the posterior spinal artery, and loss of sphincter control. Onset is sudden, progressive, evolving in minutes or few hours. Immune-mediated myelopathies, you have demyelinating disease, either multiple sclerosis or neuromyelitis optica, can present as acute transverse myelopathy. Glucocorticoids consisting of IV methylprednisolone followed by oral prednisolone are indicated for moderate to severe symptoms. Connective tissue diseases like SLE, APS, and sarcod can also produce ATM. Other cause of ATM are idiopathic. Infectious myelopathies, herpes zoster is the common viral agent. Others are HSV1 and 2. Antivirals may be appropriately started pending laboratory confirmation. West Nile virus can cause a polio-like syndrome and affect the anterior horn cells. TB is very common cause in some countries like India. Schistosomiasis is an important cause worldwide. So how do we differentiate compressive from non-compressive myelopathy? Compressive myelopathy, it is amenable to treatment. Imagine it's a disc prolapse, abscess, tumor. It is amenable to treatment. Non-compressive myelopathy is like demyelinative. We can't do much other than giving steroids. So they are not usually amenable to treatment. Antecedent symptoms, neck pain, bladder disturbance are common in compressive myelopathy. They slowly evolve. So antecedent symptoms are common. Whereas non-compressive myelopathy, antecedent symptoms are not present. The causes of compressive myelopathy are like malignancy, abscess, hematoma, herniated disc, vertebral pathology. For non-compressive myelopathy, it is vascular, inflammatory, and infectious. MRI scan usually is abnormal in compressive myelopathy. You can pick up tumor, you can pick up abscess, you can pick up disc prolapse, but usually MRI is normal. For example, vascular lesions, demyelinative lesions, not much can be picked up by MRI. The chronic disorders are spondylitic myelopathy, which is one of the common cause of chronic cord compression with gait difficulty in elderly. They present with neck and shoulder pain, spastic paraparesis. Leheret sign is very important when you are thinking of spondylitic myelopathy. What is Leheret sign? It's otherwise known as Barber chair sign, a short, intense sensation that feels similar to an electric shock passing down the neck and spine and radiating to the trunk and limbs. When you ask them to flex or extend, what happens? There will be electric shock-like sensation going down the spine because of the posterior column involvement, especially in cervical spondylosis. A tendon reflex in the arms is often diminished at some level, and urinary incontinence may occur in advanced cases. Diagnosis by MRI and treatment is surgical. This is about cervical spondylosis. Then we have vascular malformations, an important treatable cause of progressive or episodic myelopathy. Vascular malformations may occur at any level. Diagnosis is often suggested by contrast MRI, but is confirmed by selective spinal angiography. Treatment consists of microsurgical resection, endovascular embolization of the major feeding vessels, or a combination of the two approaches. One of the common causes like cervical spondylosis is the AV malformations. They present slowly. AV malformation is the connection between the artery and the vein without intervening arterioles or capillaries or veins. So it presents slowly because of the compression, like because of the venous congestion or because of ischemia. And then it tends to change with the postures or Valsalva maneuver because of the differential blood supply. So AV in a middle-aged man, especially a middle-aged person, coming with a slowly progressive weakness, especially from the thoracic level downwards, one of the important differentials to be considered is vascular malformations. And it is to some extent amenable to treatment like embolization of the major feeding vessels. Retrovirus associated myelopathies, infection with human T lymphotrophic virus HTLV1 may produce a slowly progressive spastic paraparesis with variable pain, sensory loss, and bladder disturbance. Diagnosis is made by demonstration of specific serum antibody, and treatment is symptomatic. A progressive vascular myelopathy may also result from HIV infection. One of the important MCQ question: HIV infection causes what kind of myelopathy? Vascular myelopathy. Syringomyelia, as I've said earlier, it is a central cord syndrome. Cavitary expansion of the spinal cord resulting in progressive myelopathy, may be an isolated finding or associated with protrusion of cerebellar tonsils into the cervical spinal cord, known as Chiari type 1. It produces dissociated sensory loss. Again, an important MCQ question. The moment you see dissociated sensory loss, you keep searching for syringomyelia because that is the answer they are expecting. So dissociated sensory loss, classic presentation is loss of pain and temperature sensation due to crossing spinothalamic tract involvement, but sparing of touch and pressure vibrations due to intact posterior column tract. There's a loss of pain and temperature sensation in the neck, shoulders, forearms, and hands with areflexic weakness in the upper limbs and progressive spastic paraparesis. Why is it more common in these areas? Because syringomyelia has a tendency to affect the cervical region. Subacute combined degeneration, vitamin B12 deficiency. Vitamin B12 is very much important for myelination. Of these three tracts, spinal cord, always remember three tracts: posterior column, pyramidal tract, and spinothalamic tract. Of these, posterior column and pyramidal tract are well myelinated tracts. Spinothalamic tract is the least myelinated tract. So when there's a vitamin B12 deficiency, or which is vitamin B12 is responsible for myelination. So when there's vitamin B12 deficiency, it is the posterior column and pyramidal tract which tend to get affected because they are well myelinated tract, but spinothalamic tract is not affected because it's the least myelinated tract. That's why even in demyelination like multiple sclerosis, posterior column and pyramidal tract are affected more because they are well myelinated, whereas spinothalamic tract is not affected that much because it is the least myelinated. So vitamin B12 deficiency, always think that the posterior column and pyramidal tracts are involved because they are well myelinated tracts. And B12 is essential for myelination. So paresthesias in the hand and feet, early loss of vibration position sense, posterior column, progressive spastic ataxia, again posterior column, areflexia due to associated peripheral neuropathy, large fiber neuropathy, mental changes and optic atrophy may be present along with the serum macrocytic anemia. Causes include dietary deficiency, especially vegetarians, gastric malabsorption syndromes, including pernicious anemia. Diagnosis is confirmed by a low serum vitamin B12 levels, elevated levels of homocysteine and methylmalonic acid. Treatment is vitamin replacement beginning with 1 milligram of IM vitamin B12 repeated at regular intervals or by subsequent oral treatment. Hypocophic myelopathy, clinically nearly identical to subacute combined degeneration, except there is no neuropathy. Low levels of serum copper and usually ceruloplasmin make the diagnosis. Excess zinc injection is one of the causes. Treatment is oral copper supplementation. In fact, a lot of dental creams may have zinc, and this can cause, excess zinc can cause copper deficiency. So always we need to inquire about the content of the paste they use. Multiple sclerosis, spinal cord involvement is common and is a major cause of disability, especially in progressive forms of multiple sclerosis. Tabes dorsalis, syphilis, tertiary syphilis, neurosyphilis. It may present as a lancinating pains, gait ataxia, bladder disturbances, and visceral crisis. They'll have several abdominal pain. And another important medical, and the question they can ask, what are the medical causes of abdominal pain? What are the medical causes of the abdominal pain? One is the visceral crisis because of the tabes dorsalis. Two, diabetic ketoacidosis. It can also present with abdominal pain. Then acute intermittent porphyria, it also can present as abdominal pain. Inferior wall MI, basal pneumonia. These are all the important medical causes of abdominal pain. So when a person comes with abdominal pain and paraplegia, we need to think of tabes dorsalis. They have Argyll-Robertson's pupil, that is accommodation reflexes present, but pupillary light reflexes absent. The other signs are areflexia in the legs, impaired position vibration sense, and rhomboxia. Hereditary spastic paraplegia, progressive spasticity and the weakness in the legs occurring on a familial basis, may be autosomal dominant, recessive, or X-linked. Then we have the adenomyeloneuropathy, X-linked disorder, that is a variant of adenomyeloleukodystrophy. Usually it affects males and have a history of adrenal insufficiency and then develop a slowly progressive spastic paraparesis. Female heterozygotes may develop a progressive myelopathy without adrenal insufficiency. Diagnosis is made by elevated long-chain fatty acids in the plasma and in the cultured fibroblast. Allogenic bone marrow transplantation has been successful in slowing down the cognitive decline in ALD, but appears to be ineffective for myelopathy. Nutrition supplements like Lorenzo's oil has been attempted without evidence of efficacy. Right. So far, I discussed the differential diagnosis. You may get confused. How do we approach? There are so many causes. I'll tell you a very, very simplified, superb, spectacular approach. A diagnostic evaluation, simplified approach, just 4 steps. When you see a spinal cord disease, don't get tense or don't get stressed. All you need to go is to go systematically, step by step. There are basically 4 steps. If we go systematically, it is easy to clinch the diagnosis. The first step is to perform an MRI of the spine to rule out a compressive etiology, which may need urgent evaluation. The first time a person comes with paraplegia, get MRI done first. You are trying to rule out all compressive lesions like a neoplasm, abscess, disc prolapse, tuberculoma. So first step is to take an MRI, rule out a compressive lesion. Second step, once compression is excluded, the next step is to confirm the evidence of inflammation by MRI's contrast study, gadolinium enhanced, and CSF, cerebrospinal fluid, to differentiate between inflammatory and non-inflammatory etiologies, as their treatment modalities are different. So once MRI is done and compressive lesions are excluded, then we do MRI with contrast enhancement to find out the inflammatory lesions. We do CSF to find out whether it is because of an infectious etiology or a non-infectious etiology. The third step, if there's evidence of inflammation, the next step is to search for the cause of inflammation, as it can be due to demyelination, infection, or secondary to systemic conditions like SLE. And finally, the fourth step is that when there's no evidence of inflammation which exists, consider non-inflammatory etiologies like vascular, nutritional, metabolic, radiation, inherited. So just 4 steps, we can clinch the diagnosis. So this is an overview. Step 1, we take MRI to find out whether it's a compressive lesion. Step 2, we do MRI, contrast enhancement, and CSF to find out whether there's evidence of inflammation is there or not. Step 3, we go for associated features, whether there is infectious signs or systemic etiology or demyelination site. And finally, 4th step is analysis by CSF analysis, ESR, or MRI imaging. If it is a longitudinal segment, more than 3 segments involved, it is NMO, neuromyelitis optica. Only short segments are involved with periventricular etiology. You think of multiple sclerosis, or only if the conus medullaris is involved, we think of MOG spectrum. So this is an overall picture. The slide is present. You can go later and see all the 4 steps by which we can clinch the diagnosis of a spinal cord lesion. So what are the treatable causes? We've talked so much, but the person is interested in his treatment. So what are all the treatable cause of paraplegia? A person comes with paraplegia, you need not think there's not much treatment. There are so many treatable causes of spinal cord disorders. Compressive lesions like epidural, intradural, neoplasm, abscess, hemorrhage, spondylosis, disc, or fracture, they can be treated. Vascular, like arteriovenous malformation, we can do embolization. Antiphospholipid antibody syndrome, we can give anticoagulants. Inflammatory, we can give steroids like multiple sclerosis, neuromyelitis optica, transverse myelitis, sarcoidosis, SLE. Infections, viral, we give antiviral agents. Bacterial, TB, we can give anti-tuberculous drugs. Developmental, syringomyelia, meningomyelocele, tethered cord syndrome, surgical intervention may be possible. Metabolic, like subacute combined degeneration, we can give vitamin B12 supplements. Copper deficiency, we can give copper, ask him to cut down on zinc. Though these are all the simplified approach. Now, having understood all the concepts and diagnostic approach, what is the best clinical approach? This is very, very important for students. Suppose a case of paraplegia comes, what is the best clinical approach? I feel this is the best clinical approach. A careful history and physical exam can help identify a myelopathic syndrome with various patterns of spinal cord involvement that may narrow the differential diagnosis. So history, what are all the important points? History, his story, that is history. So listen carefully to the patient's story. Bilateral symptoms such as numbness or weakness in both legs or arms suggest a spinal cord localization. Crossed symptoms with weakness in one leg and loss of sensation, spinothalamic tract in other are indicative of a hemicord syndrome like Brown-Sequard syndrome. History of spasms or stiffness in the extremities with a band-like tightness in the trunk is consistent with the spinal cord lesion. Gait disorder in which there's a primary sense of instability that is disproportionate to the degree of weakness or numbness is suggestive of spinal cord lesion. Cervical spondylosis. A sensory level is common in spinal cord disorders and is often described as a zone in the trunk beneath which the sensations diminish. Numbness below the umbilical line with a T10 sensory level. Although urinary urgency, hesitancy, and anal sphincter dysfunction are commonly associated with myelopathy, they can sometimes be absent unless late in the disease, most prominently in compressive disorders of spinal cord like spondylitic myelopathy. Lermit sign, an electric shock-like sensation to the back, illustrated with the neck flexion, can be present in lesions affecting the posterior columns of the cervical spinal cord, especially multiple sclerosis and cervical spondylosis. Intermittent lesions are less likely to cause pain and more likely to cause symptoms related to the disrupted tracts such as bowel or bladder dysfunction from involvement of the autonomic fibers. Anterior horn cell involvement can produce fasciculations, involuntary muscle twitches with the muscles lost in the affected myotomes. So you can see again the tracts, the sensory on one side, the motor on one side, more important the corticospinal tract, pyramidal tract, and the spinothalamic tract. So depending on which tracts are affected, symptoms can include limb weakness, muscle stiffness or cramping, sensory changes or autonomic dysfunction manifesting as bowel, bladder or sexual impairment. Determine the dermatomal level at which deficits occur aids in localizing the lesion and is hallmark of the spinal cord dysfunction. Corticospinal tract injury acutely causes flaccid paralysis, often referred to as spinal shock. During this acute period, reflexes and autonomic function may be depressed, but after days or weeks from the insult, weakness to hypertonia and brisk reflexes dominates the picture, usually with extensor plantar response, the Babinski sign. A lesion in the sensory tract produces sensory level pinprick testing, which marks the most caudal transition between normal and abnormal sensation. An autonomic level can be obtained by scratching the skin along the spine for a wheel and flare response. The lack of flare indicates disruption of the autonomic fibers. The dorsal columns are the large fibers, sensory fibers, that carry pressure, vibration, proprioceptive, and localized touch sensation. A lesion in these fibers leads to diminished vibration sense and produces gross deficits in imbalance and gait dysfunction. The identification of tracts involvement helps to identify symptoms of spinal cord involvement, which leads to a targeted differential diagnosis. So here you can see the syndrome, the tracts, and the differential diagnosis. If it's a complete cord lesion, bilateral spinothalamic tract, dorsal column, corticospinal tract are affected. So the common differential diagnosis are non-specific, any major trauma, hemorrhage, or inflammation. If it is Brown Sequard or hemiquard syndrome, ipsilateral dorsal column and corticospinal tract involvement with contralateral spinothalamic involvement, again it could be non-specific or trauma, compression, inflammation, vascularization. If it is only dorsal column which is getting affected, it could be syphilis or multiple sclerosis because it affects the large fibers. Posterior spinal artery, copper deficiency, vitamin B12 deficiency, subacute combined degeneration, posterior lateral cord, bilateral dorsal columns, and corticospinal tract because they are well myelinated tracts, and vitamin B12 is essential for myelination. So these two tracts are predominantly affected. Spinothalamic tract is least affected. So vitamin B12 deficiency, E deficiency, copper, zinc toxicity, HIV associated vascular myelopathy. Anterior cord, if it only anterior spinal artery syndrome, it affects only the corticospinal tract and spinothalamic tract, anterior spinal artery occlusion, inflammation, or anterior spinal artery infarction. If it is a central cord, there is bilateral spinothalamic tract fibers, autonomic fibers, and corticospinal fibers being affected. The differential diagnosis, syringomyelia and trauma. If it is anterior horn cell poliomyelitis, the motor neuron anterior horn cells, then it could be adenovirus like West Nile virus. I tell you, West Nile virus affects the anterior horn cells. It predominantly presents as polio-like manifestation. Enterovirus, polio, progressive muscular atrophy. If there is a combined anterior horn cells, element sense, and human sense, you should always think of motor neuron disease, anterior horn cell and cortex, like amyotrophic lateral sclerosis, compressive radiculomyeloneuropathy. If only anterior horn cells are affected, it is called progressive muscular atrophy. If upper motor neurons are affected, it is called as primary lateral sclerosis. If both together are affected, it is called as ALS. So combined anterior horn cells and cortex, you have to think of ALS. If it is only cornus medullaris, it could be a corticospinal tract, spinothalamic tract, dorsal column, or autonomic fibers. You have to think of compression, inflammation, spinal cord infarction. So again, I tell you, there are so many causes. What is the best bet? How do we remember? In fact, if the White Army gives an opportunity, I'll be talking about the memory enhancement techniques next week. Always try to make a mnemonic out of it. When you make a mnemonic out of it, it's easy to remember. As I said in the beginning of the lecture, birds. C5 innervated muscles are birds. I can easily tell. Anytime you ask me what is C5 innervated muscles, I can tell it is birds, it is biceps, infraspinatus, rhomboids, deltoids, supraspinatus. Why? I made a mnemonic out of it. Likewise, spinal cord lesions, the mechanism, you can make a mnemonic of it, which is known as vindicate. V-I-N-D-I-C-A-T-E. V is for vascular. I for infection and inflammation. D is for drugs like toxic or degenerative. I is for iatrogenic or idiopathic. C is for congenital. A is for autoimmune or anatomic. T is for trauma. E is for endocrine and metabolic. So always remember the mechanism of spinal cord disorders. It could be only vindicate. V-I-N-D-I-C-A-T-E. Time course. Again, very important, history taking. You're listening to his story, history taking. Time profile is important. The temporal profile of the illness is important. If it is hyperacute, it has to be compression or vascular. If it is acute to subacute, it could be infection, inflammation, compression, vascular or neoplasm. If it is chronic, going on for a long time, it could be infection, toxic, metabolic, degenerative, spondylosis, compression, vascular. An acute presentation with plateau, vascular, less commonly infection and inflammation. Acute presentation with progression, compression, infection and inflammation. Intermittent flares, inflammation, multiple sclerosis, dural arteriovenous fistula, especially when they have increased symptoms due to change in posture or Valsalva manual. Insidious chronic myelopathies. So acute deterioration with plateauing, think of vascular. Progression, structural abnormality, infectious, inflammatory etiology. Progression with intermittently flaring process, think of dural arteriovenous fistula or multiple sclerosis. Slowly and steady progression over years, think of chronic myelopathies. And then finally, you go for the MRI. Abnormal cord signal on MRI is usually not specific for a single disease, but individual pattern of abnormalities circumscribe the list of possibility. If it is a longitudinal extensive, there are many possibilities, but important is neuromyelitis optica. The other being inflammation, post-infectious, vaccine, paraneoplastic, SLE, Sjogren, sarcoidosis, atypical multiple sclerosis, Behet's, vascular neoplasm, toxic metabolic. But longitudinal extensive, always think of neuromyelitis optica, NMO. That's why I made it in bold letters. Short segment, always think of multiple sclerosis, less likely NMO, MS. That's why I made it in the bold letters. There can be other like cord trauma, vascular, most causes of longitudinal extensive lesions can also cause short segmented lesions. And if it is central lesion, think of syringomyelia. But there are other causes like spinal cord infection, spinal cord trauma, neoplasm such as ependymum. So when you take MRI in a case of paraplegia, longitudinal extensive, think of neuromyelitis optica, short segment, think of multiple sclerosis, central lesions, think of syringomyelia. Then we do CSF studies, cell count, protein, glucose to find out infectious etiology, oligoclonal bands, immunoglobulin index for demyelination, autoantibodies, NNGO spectrum, demyelination, inflammatory, specific viral or bacterial antibodies and PCR infections, flow cytometry, cytology for malignancies. Yeah, this I've given extensively, exhaustively, and tried to cover in 1.5 hours all the important A to Z concepts of paraplegia. But then if you need to go in detail about the individual subtopic of the various causes of paraplegia, you can always refer to my YouTube channel, Dr. Sreenivas Medical Concepts, where I have more than 5,730 subscribers and 220 videos. So individual topics, I made it in my YouTube channel, Dr. Sreenivas Medical Concepts. You can go. If you have any suggestions or comments, you can always post to me. I'm willing to respond, or you can post it to my Dr. Sreenivas Medical Concepts YouTube channel or sreeklpm@gmail.com, my email. Yeah, this is the book Focus Neurology. I put almost all the concepts of neurology in a question answer format, which is available in Focus Neurology book, written by me, published by CBS Publishers and Distributors. It has become so popular that it went for a reprint within 3 years of its publication, published by CBS Publishers and Distributors. It is available online from all leading bookshops, especially Amazon. Yeah, again, I thank from the bottom of my heart for the wonderful opportunity given by the White Army, especially Dr. Kishan Rao. But for him, I would not have an opportunity to share and express my knowledge to the students across the country. What a wonderful and what a lovely platform the White Army has given to me. I'm always indebted to the White Army and Dr. Kishan Rao for this wonderful opportunity. Thank you, sir. Over to you, sir. And I think I finished within 1.5 hours, the stipulated time.
Thank you, sir. That was a wonderful lecture, sir. It was so great to hear from you, sir. You made the concepts of paraplegia very easy to understand, sir. So we have one question, sir. Someone is asking how to the basic differences between compressive myelopathy and non-compressive myelopathy, sir.
Yeah, I think I put it in tabular column also. Compressive myelopathy, there will be antecedent symptoms. There will be a lot of time for the manifestations to occur. Whereas, yeah, the compressive myelopathy, it will take a lot of time for the symptoms to develop. For example, remember abscess or disc prolapse or tumor, it slowly starts compressing the spinal cord. It takes a lot of time for the symptoms to manifest. So there will be antecedent symptoms. There'll be a lot of symptoms for a long duration and then presents with the paraparesis. But in a non-compressive myelopathy, like a transverse myelopathy, they present suddenly. And compressive myelopathy, usually tumor, abscess, this prolapse, they are amenable to treatment. Whereas non-compressive myelopathy, it is not amenable to treatment. The causes of compressive myelopathy are like malignancy, abscess, hematoma, herniated disc, or vertebral pathology. For non-compressive myelopathy, it is vascular, inflammation, and infectious. Since it's a compressive myelopathy, it is structural lesion, it can be picked up by MRI, and therefore MRI is usually abnormal. Whereas non-compressive myelopathy, there are not much changes, and it is usually not much, MRI is not much helpful in non-compressive myelopathy. We go by CSF studies and other associated findings. So these are the fundamental differences between a compressive myelopathy and a non-compressive myelopathy.
Thank you, sir. There is another question, sir. With regarding to the pain, one person is asking, sir, what is meant by funicular pain?
Funicular pain is basically seen in an intramedullary lesion. It is non-specific, diffuse, unlike the radicular pain which you see in extramedullary lesion. You have the spinal cord, you have the dorsal root entering, you have the motor root leaving the spinal cord. So if there's a lesion, an extramedullary lesion, it goes and compresses the dorsal root. So there's a radicular type of pain distribution, C5, C6, or C7. So you have a typical pain, shooting like pain. When a person coughs, the intraspinal pressure increases and the lancinating pain increases. The pain getting aggravated by cough is a root pain, an extramedullary lesion. Whereas if it's an intramedullary lesion, it's a tract. So it will not be a very specific pain. It will be a diffuse, non-specific, mild form of pain. That is funicular pain.
Thank you, sir. There is one question from ADM, sir. He's asking how to differentiate between autonomical dissociation from ataxia.
No, I didn't get it. Ataxia from?
Autonomical dissociation, sir.
Autonomical. What is autonomic? What does he mean? I don't understand. Autonomical dissociation.
Oh, okay, sir. There is also another question, sir. Can stroke cause myotonic dystonia?
Can stroke cause myotonia?
What?
Myotonia.
Myoclonic dystonia, sir.
Dystonia is because of co-contraction of agonistic and antagonistic muscles. There are so many forms that you can be, task-specific dystonia or developmental dystonia, spinal myoclonus. Yeah, it can. You have spinal type, you have the cerebral, you have task-specific. Yeah. In fact, it is seen in degenerative disease also, neuronal spheroid lipofuscinosis. You see in SSP, post-measles, subacute sclerotic parenchymal, you have myoclonus. So there are varied causes of myoclonus.
Okay, sir. Thank you, sir. Sir, there is another question from some Isaac, sir. He's asking why there is early bladder involvement in extramedullary lesions.
Extramedullary, intramedullary lesion. Intramedullary lesion, you have the autonomic fibers, you have the corticospinal fibers, spinothalamic tract fibers, dorsal column. So early involvement is there in an intramedullary lesion.
Okay, sir. There is another question, sir. What is hyperdense MCA sign?
Hyperdense MCA sign, yeah. It is an acute manifestation of ischemic stroke. Sometimes very difficult to pick up acute ischemic stroke. For example, if you do CT scan, it may not pick up acute infarction. It may take 48 hours. So we need to go for MRI. So MRI, there are a lot of changes, early signs which we can pick up, which we can say it is acute infarction. Like you have insular ribbon sign. Likewise, you have the dense MCA sign, wherein if there is a thrombus or a thrombus in the MCA, it appears white, hyperdense, or hyperintense signal on MRI. So early appearance in the MCA, internal carotid artery, you have MCA coming up. So in MCA, if you see whitish color, opacified, hyperdense or hyperintense on MRI, you call that as a hyperdense MCA sign. It indicates an acute infarction. Most probably, he is a candidate for thrombolysis. If you can pick up that sign, it's very good, because if you thrombolyze a person, the person is going to completely recover. Within 3 hours, try to pick it up. Early dense sign, MCA dense sign, and glucose is normal, no stroke mimics. You go ahead with thrombolysis, persons will become normal. In fact, one of the very treatable and highly satisfying conditions in neurology.
Yes, sir. There is another question, sir. What is the current medical treatment for Vernicase Aphasia?
Vernicase aphasia. Actually, you have two types of aphasia, Broca's aphasia and Vernix aphasia. The superior division of the MCS supplies Broca's area and the inferior division of the MCS supplies the Vernix area. Broca's area is for fluency and Vernix area is for understanding. So when an embolus lodges into the inferior division of the MC and affects the Vernix aphasia, Vernix area, it causes Vernix aphasia. They cannot understand, but they keep on speaking because Broca's area is intact. So it is a fluent but completely nonsense speech. And on top of it, they'll not have hemiplegia because temporal lobe is affected, whereas corticospinal tract goes in the frontal lobe. So when Vernix aphasia patients are fluent and nonsense speech and no hemiplegia, so onlookers and bystanders mistake them to be suffering from psychiatric disorder and they take them to a psychiatric hospital. But once you take CT or MRI, it confirms Vernix aphasia. Broca's aphasia, on the contrary, fluency is affected, but they are not able to understand because Vernix area is intact. So it is a non-fluent but very sensible speech. And on top of it, they will have hemiplegia because frontal lobe is affected. Broca's area is in the frontal lobe is affected. So corticospinal tract is affected. They will have hemiplegia. So here fluency is affected. Here comprehension is affected. And most of these aphasias, they should recover. I repeat, they should recover within 6 months. If 6 months elapses, if the time is more than 6 months, the chance of recovery becomes negligible. So most of the time, do speech therapy, do whatever treatment, antiplatelet, whatever is possible, you do it. Because within 6 months time frame, they should recover. If they don't recover within 6 months, then chance of recovery is very, very poor. That is in general for strokes. You give antiplatelets, you give mannitol, you give heparin. But coming to the speech therapy per se, Broca's aphasias, they have found out, some studies have shown that since only fluency is affected, the motor power is affected, you can give dopaminergic drugs like bromocriptine because dopamine is helpful for movement, dopamine is helpful for happiness. In fact, when there is excessive dopamine like schizophrenia, they become excessively happy to the extent of becoming maniac and excessively violent to the extent of becoming hitting others. On the other hand, if the dopamine is less, they become sad and the movements are decreased. Classic example is Parkinson's. They have hypokinesia. They are sad and depressed. So dopamine level should be in an optimal level. So in Broca's aphasia, basically the fluency is affected. So they have tried to give dopamine because it helps in movements. So some trials have shown that dopamine may be useful, like example, bromocriptine in Broca's aphasia, but not in Vernix aphasia. But in Vernix aphasia, fluency is intact. Only the comprehension is affected. So bromocriptine, a dopaminergic agonist, may be helpful in Broca's aphasia, but not in Vernix aphasia. The other forms of treatment for all kinds of aphasia, like antiplatelets, anticoagulants, initially mannitol, speech therapy, has to be done. Maximum recovery has to occur within 6 months. If it is not going to occur, recovery chances become minimal, meager, negligible.
Thank you, sir. There is
yeah, one moment. Just since they raised the question, I want to talk about another important one is crossed aphasia. Very interesting. What is dominant aphasia? What is dominant cortex? Dominant cortex is that cortex where the speech centers are situated. Non-dominant cortex, that's cortex where the speech centers are not situated. So in most of the right hand is 90% of the time, the speech centers are situated on the left side, what we call as dominant cortex. So when a right-handed person, when there's left hemiplegia, 90% of the time is on the left, but 10% of the time it may be on the right. So a person with the right-handed person with the left-sided cortical involvement, they'll have aphasia, they will have hemiplegia. Whereas if a right-handed person, if the right side cortex gets affected, they'll have left hemiplegia. Usually they will not have hemiplegia. But in case they have hemiplegia, it is just 10%, what you call as crossed aphasia.